Let's talk about some postoperative recommendations. So as you might imagine, this can be quite subjective. So if you ask 10 surgeons, they might give you 10 different answers. I've worked with lots of different surgeons in the same practice who said driving could be done at 2 weeks versus 6 weeks versus 8 weeks, or lifting could be 10 pounds or 15 pounds or 5 pounds. It's kind of all over the board. So you have to use your judgment with some of these things. But generally speaking, we tell people not to lift more than about 10 pounds for 6 to 8 weeks. So bone healing is roughly a 6-week process in a normal patient. So that's ignoring any other factor, but just typically speaking, we hope that in 6 weeks, the bone is fairly well healed, if not 8 weeks. We personally tell our patients 2 months, so 8 weeks, no heavy lifting more than 10 pounds. That's fine, but that doesn't cover everything. Right? We can't do any bending, twisting, anything that's going to shear that sternum one way or the other. We do allow people to lift, with their elbow at shoulder height, but no higher, because once we get above that, that's going to start to stress that clavicle, which is pushing on the top of the sternum. If people are lifting anything, regardless of the weight, it should be under 10 pounds, but even if it's under 10 pounds, to keep their elbows close to their body, so not out this way, to make a lever effect on the clavicle. So keep your elbows close. As people are log rolling in bed and trying to sit up, you do have to use your elbow a little bit, but we need to keep that elbow as close to the body as we can. We also don't want people reaching back behind them. So that is causing sternal separation or distraction as we reach back behind. And one note about lifting too, if people are going to lift something, we don't want them to reach out and lift something up, even like a coffee cup or something like that. If you reach out and, let's say it's heavier than this, but they reach out and they go like that, that's going to be more stress unilaterally than if they would reach with both arms and lift at the same time, because we want the sternum as much as possible to move as a unit. So if I reach out with one arm, that might be flexing or pushing on half of the sternum while the other half isn't affected. That can pull the parts apart. It can flex it anterior posteriorly. But if I reach with both hands and I lift something a little bit more heavy than this, that can keep the sternum at least intact as it's moving, along with our arms. Lifting with both arms rather than just one arm is an important feature to mention to the patient. Also, with sleeping, we don't want people to sleep on their side, fully on their side. And a lot of people are side sleepers or stomach sleepers. Also, no sleeping on your stomach. I would argue it's not so much the sleeping on the stomach that's the problem. It's getting there and then rolling back over. Or it's your position once you're there. A lot of people, when they sleep on their stomach, they put their arms up. Now the elbow is going to be above the clavicle. So that's a problem. Sleeping on the side, fully on the side, collapses that shoulder, which puts pressure on the clavicle, which puts pressure on the top of the sternum. I tell patients that they can kind of list to one side so they can put pillows underneath their butt and their shoulder to kind of lean to one side. That takes the pressure off of the tailbone or the sacrum, just so they don't get a pressure sore, honestly. But then, to get those pillows out and roll the other side a little bit is trouble. But we just don't want to be 90 degrees fully on our side with that shoulder collapsing. If we can lay flat and just lean one, whole body leaning one way or leaning the other, that's acceptable. Finally, driving is highly variable. Some people live in big cities, some people live in small towns, some people are farmers, some people aren't farmers, I guess. Where I live in the Midwest, there's a lot of farmers that need to be driving. Now, the act of driving isn't that much different than the act of riding in a car, right? Getting in and out of the car, as long as people do it slow, they keep their elbows close, that's fine. We don't say you can't ride in a car, but we do say you can't drive. Now, the length of that restriction is variable. It might be 2 weeks, might be 4 weeks, might be 6 weeks. Generally speaking, I tell people 4 weeks. Again, use your clinical judgment. I do work with a lot of farmers that they need to get up into a combine or onto a tractor. That is a no-go. I tell them you may not do that. Now, driving in this sense means an automobile, not a semi-truck trailer, not a combine, not a tractor, not a four-wheeler. It is a normal automobile. If patients live outside of town and they live in a rural setting and they have to drive 10 miles to get the mail or something like that, I can't tell them no, but I say we do not recommend you drive for 4 weeks. Now, they use their judgment. And truthfully speaking, if they're not twisting to check their blind spots. If they're using their mirrors, they're keeping their hands down, as they move the steering wheel one way or the other, it's probably not the worst thing in the world. But if they're going to swerve to avoid an accident, that's definitely going to generate more than 10 pounds of force. If they're checking their blind spots, that's going to be a problem. If they're not checking their blind spots and they need to be, that could be an accident potential. We're putting other people at risk. So there's just a lot of factors that go into it. But typically speaking, 4 weeks no driving, but riding in a car is fine. There used to be an old recommendation of riding in the back when airbags came out, because we don't want that airbag going off against your chest. I would personally argue that if you're in an accident that is bad enough for the airbag to go off, you probably want the protection of the airbag in that accident. I would rather put a sternum back together in a patient who is alive versus someone who didn't want the airbag, sat in the back seat and wasn't protected enough and passed away because of an accident. So there is some benefit to moving the seat all the way back, so that if the seat's super close to the dashboard and that goes off, that the force of the airbag could break the sternum unnecessarily, versus if we move the seat all the way back, if they're in an accident for an airbag to go off and the seat's all the way back, they will have the protection of the airbag without the force of the airbag. Use your clinical judgment, but generally speaking, it's acceptable to say somewhere between, I would say, 2 and 6 weeks for driving. Middle of the road would be 4 weeks. And, definitely reiterate the risk to the sternum and the risk to others while you're driving. And again, please know that I'm ignoring the fact that people could be on pain medicines and things. That's not part of this discussion. They shouldn't be driving on pain meds. So there you have it. So there's some of the post-op recommendations and the rationale why.